Thank you very much, Bill. This is a real honour. I'm delighted to be able to honour Dr. Harridge, who, by all accounts, saved the Midwest Surgical Society from disappearing back in the 60s. Oh, yeah, sorry about that. Thank you. It's truly a pleasure to be here and an honour. And when I was asked to do this, I had to think, what do I talk about with a group of surgeons from different disciplines and different eras. What I've decided to do was to talk about some of the changes in the treatment of colorectal neoplasms over the last years that I can recall, and hopefully some of those changes can be applied or will be recognised in other disciplines also. So what I was talking about is the evolution of techniques. Now, just having a brief run through in the evolving developments. In the 1970s, sharp dissection of the rectum became the thing to do instead of just putting your hand in and pulling it out. This subsequently led to the total mesorectal excision, which was done very precisely. And in 1977, we started looking at the cancer databases so that we could actually document what was happening. And as a spin-off of that, the Familial Adenomatous Polyposis Registry and the HNPCC registry came along. And in this evolution, we went through the era of the circular stapler, selected double stapling in the rectum and the colon, and in 1986, the evolution of the colonic J-pouch, which was done quite selectively, and we'll talk a little bit about that as we went on. And as time evolved, all new ideas came up, and particularly with the sphincter saving operations were being performed. The idea of doing a transanal excision of lesions, of appropriate lesions, were fine. How do we make tumours that initially were considered to be bad candidates for surgery better candidates? This is where preoperative radiotherapy and subsequently the addition of chemotherapy with the preoperative radiotherapy to shrink the tumours and make them more amenable to surgery and possibly to sphincter saving surgery. The development of the ultrasound, CT and manometry certainly gave us a lot more usable and better information, enabling us to assess the more appropriate treatment managements of the patients. And this involved less local treatment, which at the time was used extensively for patients that had tumours that were considered unresectable. And in the 2000s, the more recent advances in techniques are the laparoscopic approaches and the robotic techniques now that are being evolved and evaluated in our current day. So I think the first thing that I recall with all of this is the fact that my mentors, anyway, insisted upon a very thorough clinical evaluation of the patient. You need to get basic lab work. CEA was just coming into vogue at that time also. And then as the radiology improved, patients subsequently got chest, abdomen, and pelvis CT scans, and more recently, the MRI rectal protocols, and subsequently PET CTs and just the PET scans, which gave us more and more information about the size of the tumour, the clinical staging, the radiologic staging, so that we could make preoperative assessments as to what the optimum treatment was. Now, one thing that I think has become or should be standard, is that you have to do the preoperative assessment before patients are exposed to any neoadjuvant therapy. That's not always possible in the situation that I'm in, where a lot of patients get referred after they've had neoadjuvant treatment. But for me, optimally, I prefer to see the patients pre-treatment so that you can do a good digital examination. And if that's not sufficient in the clinic, then they need to be taken to the operating room to be assessed more accurately. You can do it painlessly and assess the sphincter function. And they should all have proctosigmoidoscopy and a biopsy of the tumour, even though it may appear to be patently obvious what we're dealing with. Now, why do we need to do that? Because we need to assess for the appropriate way to approach these patients. First of all, do they need adjuvant treatment? Not every patient with a rectal carcinoma needs to have chemotherapy and/or radiotherapy. What type of excision are we going to perform? Sometimes a local excision, if it's in the lower third of the rectum, just above the anal canal, that if a resection was going to be performed, it would end up with a colostomy. A lot of the patients have appropriate stage tumours that they can be treated locally by one mechanism or another. Or what type of major excision needs to be performed? A sphincter saving or an abdominoperineal resection, or more recently, can these patients be treated by chemoradiotherapy with the intention to have that as the definitive treatment rather than an adjunctive treatment? The trends that have evolved with management of the patients is that patients are now treated with an outpatient, even their bowel preparation. Patients used to be admitted to the hospital for 2 or 3 days before, given a series of enemas, cathartics, as a means of cleaning their bowel out, but this is no longer the case. This started because of cost of admission to the hospital, the occupancy of beds, and adding to the expense. So there's also been a shift from inpatient education to outpatient education. This is mainly in the post-operative period for our operations, but there are a lot of disciplines where it's important to do some preoperative education too. A lot of the dietary manipulation, ostomy care and teaching is done as an outpatient. There have been care tracks that have developed over the years that enable patients to be treated appropriately and in a routine manner. And also the development of subacute facilities where patients can go to recover at home, or to recover before they get home to the family. So all of these trends have resulted in a shortened length of stay in the hospital. Nasogastric tubes are not used as frequently as they were. Early feeding has become more common. This was started by the Danish probably 15, 20 years ago, and now has become much more common. The use of narcotics is being reduced because it's recognized very much that narcotics decrease the bowel function and end up prolonging the length of stay. And there's a focus on quality of life measures. We consider, is a stoma necessary or not necessary, maybe permanent or temporary. And the use of databases and audits, I think, is very important for all of us, no matter what discipline we're looking at, to make sure that we're doing it the best way, the optimum way, and to understand where we are and recognize the numbers. So at the moment, the professed advantages of the laparoscopy, and I think to less extent the robot, but early mobilisation of the patients in the post-operative period. It's shorter ileus, reduced opiate requirements, lower cardiorespiratory problems, and a reduced hospital stay. And of course, it's cosmetically different without having a major incision. Now, these are professed. I'm not sure all of it is exactly as it's stated at the moment, but certainly it's evolving, and with record keeping, we'll certainly know what the benefits or the disadvantages are. So I think at the moment anyway, from my standpoint, the laparoscopy, the data is comparable with open operations. It's possible to perform a TME excision, obeying all the oncologic principles. It's possible to perform a high ligation of the inferior mesenteric artery and perform an adequate mesenteric lymphadenectomy. And for operations as you progress down into the rectum, certainly it's possible and to maintain the rectal fascia so that you stay in the planes that have been popularised by Dr. Heald, and we'll talk a little bit about that as we go on. But no matter what we do, we have to consider surgery and the biology of the tumour, because unless everything fits together, it's not going to work well. So if you have surgery which is good and biology which is good, biology of the tumour, you'll end up with a better result than if you have bad surgery with good biology. I think the tumour has to be considered and the quality of the surgery that's performed. If the biology is bad, then these are the ones where you'll end up with distant recurrences, local recurrences, needing adjuvant treatment, and there's a higher incidence of death by the tumour with patients that have bad biology. So when you have a patient that's got bad biology, when does the neoadjuvant treatment begin? Initially, when neoadjuvant treatment was initiated, there were very poor definitions on which patients needed neoadjuvant therapy. And today it's become much more refined. There's data that will establish what to do it. There's a biologic rationale for giving the treatment preoperatively, whereas initially the neoadjuvant treatment was commonly given postoperatively after the final pathology report came back. Now we have techniques that will allow us to identify those patients with nodes or more penetration into the perirectal fat to make it more suitable to give the patients their neoadjuvant treatment preoperatively rather than postoperatively. Not every patient needs neoadjuvant treatment. From my perspective, tumours in the lower half of the rectum, that is from 9 centimetres, the lower border to the anal verge, anything above that can be dealt with just as well surgically with the appropriate operations. So no patients in the upper rectum need treatment. If they're node positive, clinically or on MRI, these people should be considered for neoadjuvant treatment. And the other group that I think in any part of the rectum can be given radiotherapy to facilitate the surgery. The neoadjuvant treatment will shrink the tumour, and in the upper rectum, I think that's reasonable to do that, but not in the lower rectum also. But if it's a normal-sized tumour, only those in the lower half of the rectum are suitable. So we're looking at just the results of the T3 tumours that would be considered to have adequate surgery, that is, obeying the principles that Heald laid down. If the overall survival for patients at 5 years, if they had no preoperative radiotherapy, 52% survival. When preoperative radiotherapy was given, that goes up to 63%. And again, the same with node-negative patients, 58% no preoperative radiotherapy, 82% with preoperative radiotherapy. And if they had no positive tumour, there was no benefit from preoperative radiotherapy alone with respect to survival. There's also no difference with local recurrence rate also in T3 tumours that have an adequate operation. Those tumours that were 0 to 2 centimetres or greater than 5 centimetres, there was no difference in the overall survival or local recurrence after an operation. Those tumours that were between 2 and 5 centimetres, the overall survival was better in patients that had neoadjuvant treatment, 72% 5-year survival, and with no preoperative radiotherapy, only 50% survive. So if the tumours are looked at, examined, and administered appropriately, there's a big benefit to neoadjuvant therapy. Now, this is a group of patients that over the years I've been operated on, and just to sort of show the numbers, 60% male, about 39, 40% female, their age, you can see 63, the range of 22 to 93 years. The distance from the verge, more than half, 55% were in the lower third, 30% in the middle third, and 14% in the upper third. And about 10% of those patients were considered to be operated on for palliation alone. The curative operations, you can see the stages of the tumours that were done with curative intent, 88%. The morbidity in that group of patients over the years was 21% had some morbidity when you consider all the procedures that were performed. 20% of patients that had transabdominal surgery died, and local treatments, there was one that's not died, but had some morbidity associated with the surgery, and 1%, as you might expect, with a lot less risk of morbidity or mortality in patients that had a local operation. The curative treatments that they had, anterior proctosigmoidectomy and colorectal anastomosis, about just over a third. Almost a quarter had abdominoperineal resections, and 21% had local treatment. So there's smaller numbers of patients that had more prescribed operations, such as coloanal, pull-through operations with reservoirs, etc. Now, the morbidity and the complications associated with that, there was a 3.9% anastomotic leak, 22 out of 536 patients that had colorectal anastomoses. The 13 patients had pelvic hemorrhage, 8% of patients had a perineal infection. These were abdominoperineal operations, obviously. You can see the wound infection, two ureteric injuries, one stoma died, and a splenic laceration during the conduct of the operation, and 17 out of the 1,000 plus got a post-operative bowel obstruction. The mortality, the 30-day mortality, was 1.8%, 1.3 for transabdominal surgery, and 0.4 for patients that underwent local treatment. The recurrence rate, obeying the principles that we've laid out, was 2.8% local recurrence, and I think we'll refer back to this a little bit later when we look at some of the data that's being published with the laparoscope and the robot, and in particular the TATME, which is gaining some favour in people's thoughts. Local and distant recurrence, 1.6%, and just over 11% distant recurrences in the all-comers. Now, how do we achieve that? Well, I think part of the principles that we've learned over the years is that you need to do a high ligation of the inferior mesenteric artery. That's proximal to the bifurcation of the left colic, which divides into an ascending and descending. And so that when you're taking a rectal tumour out, it involves removing the entire sigmoid colon with the bowel being transected at the junction of the descending and the sigmoid colon. And then the dissection is carried distally into the rectum and down in the presacral space to the extent that was necessary to get an adequate margin on the tumour. That's right. The distal margin is, we've learned over the years, is related to the retrograde lymphatic spread. Now, this was much more common when tumours were bigger and more bulky when they were initially detected. There was some intramural spread, and it was considered at that time that the optimum margin distal to the tumour was 5 centimetres. Now, the conventional thinking today is that 2 centimetres is adequate. A lot of this is because they've had neoadjuvant treatment. The tumours are smaller than they were a number of years ago. There are some people who think that you can do the procedure with a less than 2 centimetre margin. I caution that I think that's going to backfire. But the most important thing is the blood supply and the ligation. But the distance is one of those areas of treatment of rectal cancers that's evolving, and in time we'll know what the distance is. Now, this is what is spoken about with Bill Heald, his Basingstoke experience. He reports a recurrence rate less than 5%, which is very similar to what we've been getting. And he notices the evidence of mesorectal implants, which is not distal to the line of transection. It's an interesting story about the sequence of events with his paper on the Holy Plain and that sort of thing. He actually visited us, or visited Dr. Turnbull in the late 70s, I think probably within 6 months of this paper being published, and spent a month with Dr. Turnbull, who demonstrated to him the importance and his technique of performing the rectal dissection between the mesenteric layers, the investing layer of the fascia of the rectum and the presacral plane, that bloodless plane which Bill Heald called the holy plane. But it was after that visit that 6 months later this paper was published and it espouses exactly the principles that Dr. Turnbull taught us. Dr. Turnbull called it an adequate dissection, and you never put your hand down there, you did it with instruments and was visualised all the way. And Bill Heald has done a great job in advancing that with the improvements in the technique of surgery, particularly with the his Pelican, what does he call it? The Pelican group, I think, moving it and taking his demonstrations all around Europe to demonstrate how it's done. I think it's probably the greatest advancement in management of rectal cancers that I can recall anyway. I think the demonstration and education about that particular plane with respect to the surgical approach. Now, this is a diagram of what he published, and you can see the dotted line in the presacral area. He took that little tit of fat that went down to the level of the levators and then amputated the bowel distal to the tumour. We always took it at that level, never believed, and even before the publicity about it, what amputated it at the appropriate length distal to the tumour, and the results were satisfactory. And subsequently, Dr. Heald has indicated that he doesn't think it's necessary to do what he did in the original drawings. But I think this is where the mistakes occur. The surgeon is doing the dissection and gets out of the plane between the investing layer and the presacral fascia, cuts down, and sometimes particularly in males, if it's the lower it goes, the more difficult it is to get down and make sure that you don't cone in onto the tumour so that you're leaving lymph nodes in the mesentery of the rectum. So abdominoperineal resection was the standard for carcinoma of the rectum. That has been clearly abandoned, and now the current standard is to perform a restorative operation, either with so that it's sphincter saving, with either the colorectal anastomosis, coloanal anastomosis, and the development of the pull-through operations, which can be the Turnbull-Cutate type pull-through operation that was adapted from a visit that went to Brazil, where Dr. Cutate, Raul Cutate, was proposing that for patients that had Chagas disease. And he saw the method that could be adapted and used for the carcinoma of the rectum in the low rectum. And actually, Turnbull and Cutate published that paper together after they individually and quite separately had the idea, but neither of them had published, and then that's when they published it together. 5-year survival, it's evolved that now we have patients with abdominoperineal sphincter-saving operations, same survival statistics stage for stage, and it's quite clear that it's a safe thing to do, whereas initially it was thought to be unsafe. So I think from that data you just say the chance of cure isn't compromised from performing sphincter-saving operations with tumours in the lower third of the rectum with the use of proper diagnosis, preoperative assessment with the new equipment, neoadjuvant treatment given appropriately, and the appropriate surgery done well doesn't compromise the chances of cure, which it was thought it did a number of years ago. Now, just want to touch a little bit on the laparoscopic resection. The data that we have at the moment, there are comparable results for competent surgeons for the same stage of the tumours done appropriately. It was hoped that there might be some decrease in hospital stay, decrease in hospital costs. The last time we looked at it, there was half a day difference in the length of stay for those that had an open operation or a laparoscopic operation. The patients that had laparoscopic on the average had half a day less in their length of stay. I think this is continuing to improve and is part of the evolution of advances in technique. Now, I happen to get a supply cost for operations that get sent to me because I was having a debate with some of the financial people about the cost of laparoscope and robots and things like that as to where it fit. And every month I get a printout that shows the cost of the equipment that gets used in the operations. The green one is my number, and the bottom one is a compilation of my partners who are doing laparoscopy. These are open cases, and you can see the CPT numbers there, and the extraordinary difference in what it costs from the use of instruments and technique between an open case and a laparoscopic case. I don't know where, I can't imagine, I haven't been able to find out. This came just a few days ago, but $5,500 in equipment to do an anterior resection is staggering. And how can it possibly? I've no doubt there's some outliers in that, and it's different. But you can see even 44155, the difference in the cost of what you put into it from the hospital supplies to do the operation is quite marked. So this is a paper that caught my attention. I have to sort of mention it, that is published in Disease of Colon and Rectal. It was in November last year, so it's within a year. And Dr. Zhang is discussing the margin on oncologic results for cancers of the rectum. And he makes the comment that people believe that less or equal than a millimetre clear on an oncologic resection is okay. So they did this study, and it showed that it was horrible. So their proposal was that you had to add chemoradiotherapy no matter what if you had an operation where the surgical margin, if you can believe it, was less than a millimetre or equal to a millimetre from the lower end of the tumour. And in the paper, they had observed that up to 33% of patients had a positive microscopic margin This was 3 major hospitals in China. It's unbelievable. This is stuff that we learned years and years ago, that you've got to have an adequate margin to do it, but you can't expect that. And this is another one that caught my eye. We're talking about the evolution of techniques that are being used. This is a patient, an editorial from October last year, where they're reporting on a training program that had been developed to try to implement the use of the transanal TME, and they're teaching people how to do this on cadavers. There were 81 experienced surgeons who'd attended this course that went over several days. 32%, almost a third of the patients, or almost a third of the participants had attempted or performed a TA-TME before going on the course. And when they looked at the data at the end of the course, 9% of the dissections were in an incorrect plane. 4.5% had an injury to the rectal wall. 20% were completely in the wrong plane and had mobilized the prostate with the rectum. 25% had a urethral injury, and 53% of all the persons who were participating in the movement indicated that they'd had at least one complication in the surgery. Now, we need to be advancing, but this is something that you can't recommend that everybody uniformly begin to use this technique for rectal cancers at this stage anyway. This is something that we need to look at very, very carefully. I don't know what the answer is, but that, to me, is unsatisfactory, and it's part of the things that we learn over the years when techniques are used, abandoned because they don't work, and I think we still have a long way to go before we can give a blessing to the use of both the laparoscope and particularly this type of technique before you can say that we're advancing the cause of doing good surgery. Thank you very much.